Many have dreams to be a medical professional. When choosing an institution for medical school, a lot of things matter. The quality of the academic and clinical programs, as well as the clinical experience. At Unimas, we offer that and more: a supportive culture, a vibrant community, diverse student and patient population, all set against the backdrop of Kuching and Kota Samarahan.
The culture here is welcoming. It is a big family. Everyone wants the next person to succeed together. We want our students to reflect back to the community today. As a community-driven university, we believe that immersing themselves and ourselves in the diversity, it creates
here, but a great environment is what we all strive for.
Everyone is committed to create a great environment to become a great doctor in the future.
Our patient population in Malaysia is remarkably diverse. Different languages and dialects will be something that we face every day once we become a doctor. So, getting to know this and learn it now make us to be more appreciate and respect. It just set us up to become a better doctor for the future.
From the beginning of the program, 25 years ago, we have adopted a spiral curriculum. As the students advance forward into their years of clinical study, we connect everything back to underlying basic biological sciences. We connect and revisit every aspect of human health, from emotions to diseases, back to its basic biological sciences.
We are introduced to clinical setting early in our curriculum. The exposure gets more as we advance through the year. It was very daunting at first, as a first-year student, to step into hospital and seeing patients. But at the same time, it's really an exciting experience.
We are committed to excel in nursing education, research, and practice. It views health as a complex and dynamic, and the client as a holistic individual. Students in this program learn in an environment that stimulates intellectual inquiry and creativity, which encourages them to be problem solvers and lifelong learners.
Here, we learn how to care, to serve, and to help. We went from zero to hero.
I really cannot pick a better place to learn and become a greatness. This is a place that belonged to my heart throughout my journey.
Come do research with us.
Come and join us at Unimas and realize your dreams.
spending your time with us. It is my great pleasure to introduce our speakers today, and both of them are prominent surgeons from the Department of Surgery, UNIMERS. I'm so proud in saying that one of the speakers is Dr. Myo Nyon, a very senior general surgeon with more than 3 decades of experience in this field. And Dr. Myo is also a fellow of Royal College of Surgeons, UK. And the other one is Dr. Aini Fariza Ibrahim, a well-known colorectal surgeon who achieved a fellowship in minimally invasive surgery and robotic colorectal surgery from Korea University, South Korea, and fellowship in colorectal surgery from Chulalongkorn University, Thailand. And she obtained her master and fellowship in colorectal surgery from Malaysia. For this talk, the first session will be given to the 2 speakers and subsequently followed by Q&A session. All participants are kindly requested to type the questions in the Q&A box, and we try to answer all of your questions. You hear the patient complain, fever, poo, pee, and etc. So today, 2 of our prominent surgeons are going to share their experience and expertise on one of the commonest and the most alarming symptoms for the patients that makes them raise the question, "Doctor, why is there blood in my poo?" Therefore, I don't intend to waste any of your time. And without further ado, let me welcome Dr. Myo Nyon, who is going to deliver his talk on peptic ulcer disease and its complications. Dr. Myo, the floor is yours. Thank you very much.
Thank you, Dr. Chi, and thank you to organizing committee, and good morning to audience. I am Dr. Myo from the Department of Surgery, Faculty of Medicine, Health Science, University Malaysia, Sarawak, Malaysia. So today I would like to discuss, and Prof. Aini will discuss regarding the bleeding from GI tract. Someone will worry if he finds blood in his toilet after his bowel motion. So he wants to know where is the bleeding point and how severe the bleeding is, and worry because bleeding is inside the gastrointestinal tract, inside the body. People will not know how much blood has been lost in the intestine, large intestine or small intestine. So regarding this topic, we divided into upper GI bleeding from stomach, and first part of small intestine we call duodenum. And bleeding from stomach and duodenum, I will discuss mainly on upper GI bleed, and Prof. Aini will discuss lower GI bleeding from intestine, especially colon and the rectum. So regarding upper GI bleed, the patient may go to nearest district hospital or specialist hospital because he found it is alarming for the blood in the toilet. Yes, it is emergency because more than 15% of the blood loss from the body will cause danger of hypovolemia, anemia, and patient may have palpitation, weakness, and lightheadedness, and even patient may have fainting attack. So this is emergency situation. Let's see what are the causes of bleeding in the upper GI tract, stomach and duodenum. So looking at these causes, the most common causes are gastric and urinary ulceration. So technically, we call peptic ulcer diseases. What is peptic ulcer diseases? What are the peptic ulcer diseases? Peptic ulcer disease is a break in the inner lining of stomach or first part of small intestines, first inch of duodenum, or sometime in lower esophagus. And related problems are called peptic ulcer diseases. So next step is, what are the causes of peptic ulcer diseases? Most common cause of peptic ulcer disease are infection with a bacteria called Helicobacter pylori. And another common cause is long-term use of non-steroidal anti-inflammatory drug and SAID, such as ibuprofen, the drugs used to relieve muscle pain, joint pain, etc. And another one is stress, is another cause of peptic ulceration. Right? These are the causes. Looking at the pathology, what are the changes in stomach and duodenum when somebody has peptic ulcer disease? So that stomach and duodenum is coated inside with the mucus layer of normal protect against acid. So that if you see the inner layer of stomach, you can find a mucus that is slippery and watery, and it protects from the acid produced from the stomach, not to destroy it mucosa itself. If the amount of acid increase, or if the amount of mucus is decreased, if there any damage to the mucus, can develop an ulcer. That is the basic pathology of peptic ulceration. The main cause are H. pylori and long-term taking of anti-analgesic and NSAID, but also there are risk factors. Smoking, for example, smoking is a risk factor, and also drinking alcohol is a risk factor. Have untreated stress and eat spicy food may promote the formation of ulceration in the stomach and duodenum. According to pathogenesis, acid causes ulceration, especially when the mucus layer is damaged. So how Helicobacter pylori virus make ulceration, especially in duodenum? H. pylori, that is Helicobacter pylori, cause hyperacidity, higher production of acid from the stomach, and also direct mucosa damage to the stomach and also duodenum. How about NSAID, like analgesic drugs and non-steroidal and anti-inflammatory drugs? Hyperacidity and mucosa damage. The both pathways, they can cause peptic ulceration. Smoking can cause hyperacidity, and production of high acid production from the stomach, and drinking alcohol can cause mucosa damage. Stress may cause because of the hyperacidity in the stomach and duodenum. So we will see not only the peptic ulcer, but also H. pylori gastritis may present with the bleeding from the stomach. So now, H. pylori become a main cause of peptic ulcer diseases. Let's look at the Helicobacter pylori bacteria. It was recently found by two scientists, Mr. John Robin Warren and Barry James Marshall, from the Royal Perth Hospital, Perth, Australia, and they get Nobel Prize finding this bacteria from the stomach of the patient. The bacteria live in the stomach. Although stomach has acid media, the environment is not favorable to grow a bacteria inside the stomach. Helicobacter pylori is acid fast, bacteria acids, it can live in the acid environment, so they can cause a problem to patient. So how about H. pylori infection on the world population? It is more than half of the adult world population have H. pylori infection. The prevalence of H. pylori infection varies widely by geographic area, age, race, and socio-economic status. So H. pylori infection can cause a variety of diseases like gastric ulcer, duodenal ulcer, gastritis, and even cancer stomach. However, many people with H. pylori infection inside the stomach still no symptom, no disease. We call them as carrier of H. pylori infection. Another cause of peptic ulceration is stress. You can find stress in a road traffic accident patient or patient admitted to ICU may have stress, and that can cause peptic ulceration, acute ulceration, and also can cause bleeding from that ulcer. Now we go to the consequence of gastric ulcer and duodenal ulcer. Documented complications are perforation. The gastric ulcer can perforate. We present with peritonitis, inflammation of peritoneum, and this is also a serious condition. And bleeding from gastric ulcer and duodenal ulcer is cicatrization, fibrosis, or bleeding from gastritis involving the whole mucosa, and also bleeding from gastric erosion. So how will you treat? When someone has found blood in the stool, upper GI bleed, it is appear in color, and we call it melena, and sticky and blackish and black tarry stool. But it turns into red when you flush with the water to the feces. So this is a consequence of bleed from the stomach and pass through the intestine, denatured by bacteria inside the intestine, and change color to black. But when patient flush water to the toilet, that black become red. So if someone has blackish to turn into red by water, he will go to nearest district hospital or specialist hospital in emergency department. When patient arrive in emergency department, the main aim of treatment is resuscitation. Patient may have lost large amount of blood from the stomach and duodenum, or small amount of blood lost from stomach and duodenum. We do a primary assessment like full blood count, hemoglobin estimation, and arterial blood gas analysis, and also peripheral oxygenation analysis. Then we will do resuscitation, mainly the circulatory resuscitation. Many patients may need blood transfusion at that time. And at the same time, we will do necessary investigation like clotting deficiency, clotting profile also, right? So the next step of treatment is to stop bleeding. So resuscitation and to stop bleeding, hand by hand, take together. So to stop bleeding from this gastric ulcer or duodenal ulcer, peptic ulcer, we use pantoprazole, that is proton pump inhibitor drugs, intravenously. First dose is bolus to 80 milligram stat, intravenously given, and followed by 8 milligram per hour with the dilution with normal saline, and the drip drop by drop given up to 72 hours. So pantoprazole is H2 receptor, pantoprazole proton pump inhibitor. It stops production of acid from the stomach. How stop production of acid from the stomach, stop bleeding? It's the rationale of pantoprazole. If there is bleeding in the stomach or duodenum, blood will tend to clot. First step of blood clot formation is platelet plug formation. Platelets in the blood adhere sticky to each other and form a plug, and also platelets sticky to the bleeding point. So platelet plug formation is inhibited or the hampered by the acidity of the stomach and duodenum. So if pantoprazole stop production of acid, low acidity promote platelet plug formation faster and blood clot formation faster. So believed to stop bleeding from gastric ulcer and duodenal ulcer. So we normally give pantoprazole infusion in district hospital or in the specialist hospital emergency department, 80 milligrams step intravenously and followed by 8 milligrams per hours up to 72 hours. From top of pantoprazole infusion, patient may need direct access to the stomach duodenal ulcer and direct control of bleeding. So after resuscitation, and patient is sent to specialist hospital for upper GI scope, that is OGDS. Patient reach emergency department of Sarawak General Hospital, stabilize the patient. If patient has, for example, bleeding problem like prolonged INR, we make correction of INR by giving fresh frozen plasma. So after stabilizing the patient and the correction of INR prolonged, we will bring the patient to scope room, endoscope room for upper GI scope. Some patients are unlucky. They will continue bleeding in the emergency department, although we give pantoprazole and correction of bleeding coagulation problem. We may need to bring the scope from scope room to emergency department, and sometimes we have to do bedside scope and stop bleeding in emergency department or ICU, right? Okay, most of the patients are stabilized in the emergency department and sent to endoscopic room and do upper GI scope. So through upper GI scope, gastric ulcer appear and duodenal ulcer appear in the actively bleeding stage or signs of recent bleeding stage and ulcer without bleeding. So we classify with Forest classification. Forest classification is used to identify the bleeding is currently acute bleeding, Forest 1, or signs of recent bleeding, Forest 2, or without bleeding, clean base ulcer, Forest 3. And then if we find Forest 1 ulcer or Forest 2 ulcer, we need to do some intervention during the scope or GDS to stop the bleeding. So injection of adrenaline around the ulcer to promote vasoconstriction and stop bleeding. And also we will use argon plasma coagulation machine to stop bleeding from the peptic ulcer. So after this, another step is to take biopsy, mucosal biopsy, to confirm diagnosis of Helicobacter pylori. 1%, 2% through food and water, then you can protect yourself for infection or H. pylori by frequently washing your hands with soap or water, eating food that has been cooked completely, and clean materials are used to prepare food and handle the food. Right. So then, another point is how to prevent peptic ulceration. If your peptic ulcer is already healed, then next step is to prevent recurrence of peptic ulceration. So avoiding a risk factor like never smoke, never drink will help you prevent recurrence of peptic ulcer. Lifestyle change, regular eating, and eat more the organic materials, healthy food, regular eating.
And then it's difficult because current audience are going to be people coming from the general population and also from the medical faculty. So bear with me in terms of the nomenclatures and the names of the presentations that I'm going to have. And later on, for those of you who are going to have some questions about what are the things that you don't understand from the topics, so I can answer that in the Q&A sessions. Right. So it's gonna be, let me share 1 second. Okay, can you guys see this? Dr. Chi, can you see this? Yeah. Can somebody let me know?
Yeah, I can see. Sorry, I mute my microphone. I see. Thank you.
So can you see this?
Yeah.
Okay, fine.
Yeah,
Right, it's fine. Just stop me if I have any problem with my slides.
Yeah, sure.
Okay, again, guys. Right. So the main core topic that I'm going to talk about, because it's not fair for me just to talk the whole thing about colorectal cancer in Sarawak or even the colorectal cancer in general. But as a person who manage and practice most of the cases in the tertiary center in here, I do have some experience or some knowledge that I need to describe and also to share with all of you, and then to see what are the challenges that we face in our current practice at the moment. Right, we go back to the topic. So I have blood in my poop. It's very common. This is something that I see on day-to-day basis because they are referred to me. Either it could be from the upper GI bleed, as what Dr. Mio was mentioning before, and also from the lower GI bleed. So the difference is in terms of the color, because the upper GI bleed, which is much more of the bulk of the stomach and the small bowel, are mostly in black, whereby I do see more of the fresh bleeding. So this is important for my doctors to really diagnose and to know which part of the anatomical systems are being bled. Okay, what's important? The problem is bleeding rectal is the first telltale sign for colorectal cancers or even colorectal lesions. These people do not just have a bleeding. Sometimes they do have come with abdominal pain and altered bowel habit. What does that mean is that you normally have a day-to-day bowel opening, but sometimes you have it changed in terms of diarrhea or you have a chronic constipation. So this is the things that we investigate. We ask the patients while we're doing the screening process. Okay. Some of the talks I have here are based on my previous talks I had before. I have regards to the normal population. So what I need to tell you guys about is for what is actually the definition of colorectal cancers, what are the symptoms and factors, and who are at the risk, and some of the risk reduction strategies that we can do and can help to reduce the risk of cancers, colorectal cancers. And from the medical part, how do we do the diagnosis of the colorectal cancers, the types of surgery that we do, and last but not least, the current challenges that we have in Borneo. Now, I know the word colorectal is for some people are still very, very awkward or new or very alien, because even for me, when I embark on this specialties, not many people understand what does it mean, all right? So this is a whole view picture of your colon, rectum. Colon is actually what we call large intestine. It comes from the Latin or Greek word that means a large intestine. So normally, normal population will have about 1.2 to 1.5 meters of large intestine, whereby the small intestine is much more of a longer organ and better absorption. Then the last part, which we call the rectum, is actually a reservoir. It's actually the last part of the large intestine. And this is actually where the main problem comes, because as you know, as a large part, the excretions normally will come from this area. Okay, how does it work? In simple terms, colon is mainly for your water absorption and also parts of nutrient absorption, whereby your rectum are mostly for the defecation and water storage, hence the name of reservoir. Now, okay, so we deal a lot with colorectal cancers at the moment, but of course our data has to be on something evidence-based and also based on the audit. So on a 4-yearly basis, the Malaysia will have their own national cancer registry, which was done about 4 years ago and published in 2019. And in terms of the numbers, or in terms of the cases that we faces in the whole of hospitals in Malaysia. Whereby for us, in surgical practice or even in the gastroenterologist, we base on our practice based on guidelines. It can be international guidelines, it can be local guidelines, and last but not least, we came out with our own guidelines in 2018 to cater for our own management of colorectal cancers in Malaysia. So this is a black book. You can get it online if you Google up from the website. And then this is 80 pages guidelines that has the current management of this cancers, not just for the surgical, for the doctors, and also from primary care physicians as well. Now, last March, or in the yearly basis, we celebrate Colon Cancer Awareness Month. Comparison to, I'm sure most of you know that in October, it's more pink ribbon for breast cancers, whereby in March, it's less known, but I think we're trying to increase the awareness of this. So what we normally emphasize is that it's preventable, it's treatable, and beatable if you come at early stage or if you seek early medical advice. Now, let's look at the data. So it's going to be a bit heavy topic for some of you. What actually that we know from the registry is colorectal cancers is number 2 highest in Malaysia at the moment. So out of the numbers, we diagnosed about 15,000 new cases, and then this this is around 13.5% of all cancers in Malaysia. This is general for both male and female. And then we talk specifically on the gender disposition. So it's actually the highest in male, all right, of all cancers. I mean, it's quite not surprising because before this, we thought it was going to be like lung cancers or trachea cancers. But the last couple of years, we noted that colorectal cancers has totally become the first in Malaysia. And this contributes around nearly 17% of all new cancers in male populations, whereby in female, you can see, of course, the number one is still breast cancers, about 21,000, and in colorectal cancers are number two before the gynecological cancers, right? It's about 10%. Now, okay, what is surprising is when we taught our medical students regarding the presentations, most of the presentations will come around stage 3, late stage 2 or stage 3. But based on our registry that we just analyzed, that actually most of the population in Malaysia comes at stage 4. Okay, what does it mean is has gone beyond the normal organ, which is the colorectal organ itself, has gone either to the liver, to the lung, to the hardly bones, but definitely beyond the normal pathway. So whether this is a sign of that we're not doing enough to detect this early, or whether most of our patients are still do not understand or aware of this current situation. How are we at par with other people in the world? Of course, we can't compete with the rest because the incidents are much higher in the Western population, the Northern Hemisphere, and also in East Asia, for example, in Korea where I was working, and also in Japan. But the difference is that because they might have a very good screening systems, that hence the detections are much early on, and hence contribute to the increasing numbers. Okay, for normal people out there, how do you know you have something wrong with the colon? Okay, so besides the first presentation of having blood per rectum, some people might not have this. They just have a very big sign. They just have like, eating, just some abdominal pain. They could have comes with anemia, some weight loss unintentionally, constipation, change in bowel habit, and loss of appetite. I mean, I know for most of us in medics, these are very arbitrary, meaning this is very vague symptoms that any disease can come with this presentation. But if you investigate in details and you pinpoint what are the main concerns of the patients, I think this detection can be done much earlier. All right, now, this is the most famous questions that have been asked up until now. At this level, I never have any good answer for this because even based on the research that has been done, these are the common causative factors. I mean, smoking, alcohol, lifestyle, food, genetics, old age, these all are contributory factors. But I can't say that because everybody is doing eating certain foods that can cause it, all right? So it's still a big debate of what actually, because we do see people who are actually vegetarians with this habit. We see people who are who never take any, who takes just organic, who have it. So it's very difficult for me when they come to us in the clinic to justify what are the causes for them individually. So we always say in terms of our layman term, this is multifactorial causes of that, right? So who are at risk, of course, again, advanced or elderly patients, but mind you that at the moment, in my practice, I've seen more of younger adults at the moment. It's quite disheartening because when they come at early stage, the disease are much more advanced and the prognosis are quite grim comparison to people who are at the advanced stage, okay? Familial history, strong family history of colon cancer, certainly big factors because there are certain diseases are connected to this, all right? Genetics, again, some people are just prone to have it because of the family history. And last but not least, a smoker, alcoholic, and idiopathic, meaning that sometimes you do not know the cause of the disease. All right. We, when I was training, our methods or our modalities are mostly for early screening. We champion the early screening for any diseases, not just colorectal cancers. I think most of you might know, even for breast cancers, even for all this SHDs, heart disease or diabetes, early screening are very, very vital. Same as to us, but it's just because our screening program is not as comprehensive as what other people in other countries are having at the moment. So we can improve on this certainly, because we know that if we have it at early stage, the treatment and the prognosis are much, much better. Okay. The other two criteria that strategies that they always mention is, again, well-balanced diet and healthy lifestyle, not just for the cancers and also for normal other diseases. Right. What do we do? All right. Do we just do the history taking, which is not sufficient enough? Okay, we have to have something much more definite. So the easiest to be done in the primary healthcare centers or people in the clinic kesihatan is what we call the fecal occult blood test, FOBT. So this is whereby the patients, those patients who are being screened and higher risk are given stool sample. No, they were supposed to hand in their stool sample, whereby the healthcare workers will do the testing. So if this test is positive, then they will be referred to us tertiary centers or to the hospitals for early colonoscopy. So we at the tertiary centers, we see them mainly because of colonoscopy, and hence for me, I still feel that colonoscopy is one of the best methods to have a early screening of this colorectal cancers. Besides all these two methods, other modalities that we do mostly for advanced staging, a CT scan, either the whole body or just abdomen and pelvis. Tumor markers, which is still debatable, because some of us, we notice that patients do have a very normal tumor markers. Others are also sigmoidoscopy, which you don't see the whole colon, you only see the left side, and also PET scan, which is much more advanced and much more pricey. Right? This is not common. All right. How do we diagnose? As a medical personnel or in surgical base, so we do not just base on one criteria. So we have to have a few investigations to confirm before we let them know the diagnosis, even the stage of it. Number one, of course, the sampling of the tissue based on the colonoscopy. Number two, the CT scan based on the imaging. It can be also from MRI for pelvis, and also sometimes we add on the tumor markers if it's very high. So all these three criteria, so 3 or 4 criteria, can have a conclusion of what is the diagnosis for the patient before we plan for further treatment. Right. Treatment, this is what we do on the daily basis. Okay, we currently because of the MCO, we don't do as much as what we did before. So we embark on surgery mainly. Prior to that, after that, they can also have chemotherapy based on the stage, and radiotherapy based on the position if it's a rectal cancer. So this is a multi-modalities of treatment that patient can have if they being diagnosed with colorectal cancers. And the surgical treatments are various options. You have invasive, we have open surgery, we have transanal, even robotic. But of course, robotics such is still a new thing here. Now, what we do, so that we will remove based on the location of the cancers. Of course, we're not going to remove the whole colon. It's not feasible unless there's some certain disease that is associated with that. Based on our resection will based on where the position of your tumor is, right? Because even the layman will ask us, the patient will ask us which side of the colon that you're going to remove, left side or right side, or the whole colon, or just the lower side. All right. So, but in detail of the consultation can be done with the specialist in charge. Okay, so that is the overview. I know it's very short overview of colorectal cancers, but as long as people understand the importance of having awareness of it and help us to do the screening for the patients, and also for us to detect these cancers earlier, so we have a better treatment. And also for people to understand that, currently, because of we have all the services to treat any stage, not just from the surgical side, the medical side, the oncology side, and also from the radiotherapy side. Now, let us look at our own data. Okay, in Sarawak, at the moment, I work in Sarawak General Hospital in Kuching. Okay, this is the main general hospital that covers I think most of people know the geography of Sarawak is very, very vast. So we cover up until Lundu area, Betong, and some border to Cebu, because in Cebu, which is another second biggest hospital, we have another colorectal surgeon, so Mr. Cheng, who covers in that area, right? Now, so at the moment in hospitals, as you know, I am not under Ministry of Health. I've never joined Ministry of Health before, because when I came back, I straight joined UNIMAS as part of the academic team. So, but because of the practice, because of my workload, my patients are in the hospital, so I work in the hospital under the umbrella of the HOD, and also I have a team of medical officers that help me in my practice. I know it looks small, but the work we do doesn't tally with the numbers, so the workload are much better. So in 2019, the Ministry of Health came out with the data of what other workload that we see on day-to-day basis, and this could really portray what are the current things that we do in the hospital. What I can see in terms of the current challenges is, as what I mentioned before, there are increasing numbers of colorectal cancers in young adults, right, in Sarawak at the moment. I know before this, we always say that the risk factors are people above 50s, above 60s, but I do see patients now around the 30s or even 20s, or mostly in the 40s, who are diagnosed with colorectal cancers. The problem is, if these people comes to the primary care or even to normal doctors, people will never think this could happen in young ones. So hence they are not being referred, they're being treated. If they have PR bleed, they have blood in the stool, people will just contribute that to hemorrhoids, which is very common, right? So hence the diagnosis will be a bit delayed. I mean, you can't blame them, because this is not the normal practice for us to understand that, everybody with blood in the stools are cancers. So it's hard to put the bother about who are people that we need to send. Do we need to send everybody for screenings or not? So this is still the big hot topics at the moment. Secondly, of course, the logistics, the geographical challenges. If people who have worked in Sarawak, they know we have a very, very difficult access to the rural areas. Some of our patients will take them about a day or two just to come to the hospital even for screening or even for a follow-up. And then this, in the era of COVID, is going to be much more difficult because of the border closures and also because of the restricted movement. Hence why last year we see lots of advanced cases comparison to before. Number 3, lack of manpower and colorectal specialists in Sarawak. At the moment, I do provide the service for the hospitals. We have another specialist, colorectal specialist in Cebu, as I mentioned before. But at the moment, in around Kuching, we don't have as many or as what the KKM, the Ministry of Health wanted. So those people are still under training, and then most of them, the problem is being sent or being put into the hospitals mostly in the West Malaysia, because they are much more well demanded there. So the main for us in the colorectal training, they try to train as much local as possible so that people will come back and serve the area. again, the last but not least is actually difficulty in doing colorectal cancer screening. IFBT is very good if you get the target population, if you can reach the population. But if the population do not come to you, we don't really do a mass screening or when we go around the whole country to do the testing, because it's just not feasible, all right? So what now we have is more of what we call opportunistic screening, where they have symptoms, we do the test, or whether they have risk factor, we do the test. So we don't do as a normal overall population screening as some in Japan or in Korea does, all right? Is this going to change? I think we could, all right? It's still going to be a long way to go, but I think this certainly has a way to go around it. Okay, let's look at our data in Sarawak General Hospital. Again, thank you to Ministry of Health for this. Right, so in 2019, over there, we actually performed a very increasing number of cases. It's about nearly up to 4,000 cases in the whole of 2019, definitely higher than before. And this just entails not just the surgery, it entails even the endoscopy procedures and small other procedures. All right. If you look into the topic, the top surgeries that we done are mainly for cancers. Right. So how are we at par with other hospitals in Malaysia? Okay, in terms of colonoscopy. I mean, mind you that we do have a very limited number of scopes, because scopes, colonoscopy is not a cheap instrument, all right? But we have to cater for bigger population. So sometimes we have problems in terms of scopes is worn out, has to be changed, has to be repaired. Hence, sometimes that reduce the number of colonoscopy that we had at the moment. I think that's what happened. If you see from this, in 2017, I wasn't here, but remember that we had such a limited number of scopes. Hence, that tallies with the number of reducing number of colonoscopies that we did. But on a yearly basis, we normally do about 1,005 or 1,003 colonoscopy per year. This is quite a lot for tertiary hospital. Now, so if you look at this data, when they published this in 2020, I just came back in mid-2019. But because I am not under Ministry of Health, so my contribution to the hospital is not considered as part of the colorectal surgeons. But we do, because we did a lot, so the numbers and then the patient will have a stoma, which why they have to pass the motion from the back, right? So we have good numbers again in 2009 and in that 3 years period. Okay, number one in the whole of Malaysia for center without CRC surgeon. Ultra-low is another what we call sphincter saving procedure. Previously, we do lots of APR, but we understand that people do not want to have stoma. Stoma is whereby you have to have the bag either temporary or permanent, and it's going to cause lots of problems and also lots of dissatisfactions in patients. So we try to preserve this. So hence the current procedure that we do most are what we call ultra-low entry section. We have to remove the tumor, we join it back together, and patient later on can live without a stoma. Low entry section, again, much more another complex procedure that normally done by colorectal surgeons. We do a lot of this as well at par to other hospitals with CRC surgeons. And anterior sections is the most common ones. I mean, this anterior sections, what it means is just basically remove the part of the rectum based on the anatomy just now, and also part of the rectal sigmoid area. So this actually can be done with most of the general surgeons too. Okay, now why I put a star here, Hartmann procedure is what we call emergency procedures. As you know, because of the logistic perhaps, or because of the delayed diagnosis, most of the patients we see comes under emergency. So they will have either what we call obstructed cancers, perforations, is block, bleed, or burst, right? So they mandate emergency surgery, and because of the situation, sometimes we can't even join it back together, anastomosis we call it, and they ended up with Hartmann procedure. So I'm not sure whether we should be very proud that we have the highest number, but certainly this is main bulk of our emergency procedures, Hartmann procedures. The rest, either left, right, or sigmoid colectomy. Again, we do a lot, as what other hospitals do around Malaysia. And the workload is still going to be increased later on. Total colectomy is what we do when we remove the whole colon, not for everybody. Certain patients with cancers, or not just cancer, some inflammatory bowel disease, we do this not as often. Okay, so number 2. So based on this, what on the data had shown, based on our own experience, based on what we deal with on day-to-day basis. So there are a few things that I think, in the services in Sarawak should improve, or will improve, or can be improved. Okay, or this is just aspirations from us in the medical fraternity. Number 1, of course, to have more specific surgeons, colorectal surgeons, or even general surgeons with specific interest in colorectal surgery. I know some, because of the complexity of the disease, because of the area that we operate, not many, even the general surgeons are quite familiar with this kind of procedures. But once, for example, as I mentioned before, the Hartmanns or the anterior sections, the colectomy should be the bread and butter of most of general surgeons. So, then we talk about training more people, training more fellows, training more surgeons to be sent and to be covering this area of Borneo. Number 2 is because of the heavy workload, because of the lack of manpower, we are lacking in our research data. So enhance the research agenda is one of the main priority as well, because the data are there, but it's just nobody has been able to compile it or to do certain research with the data that's available. Number 3 is, this is what we call the unsung heroes. These are my nurses and my enterostoma therapists. These are the workers that work with the patient that has colorectal cancers, surgeries, and sometimes they are with stomas. Right? So without them, it's difficult for me to become the advisors for these patients, because this will be a lifelong thing for some of the patients, especially people with the lifelong stoma. So hence, at the moment in Sarawak General Hospitals, I have a very good group of enterostoma therapists, what we call the ET nurses. They are world-trained enterostoma nurses, and they are very, very up to date with their current management. And last but not least, is this something that I really wish that is going to be a big thing in future, doing a comprehensive screening program for colorectals, not just in public fraternities, in academic fraternities, or even in private fraternities, because I think all of the population can contribute to this success of screening program. Of course, if we talk about the Western or even the East Asia, whereby they have the insurance, which make them compulsory to have a screening, but in Malaysia now, I think it's, with our healthcare system, is still not feasible at the moment, but certainly we can try to adopt it in our system. Okay, I think that's about it. Thank you so much.
Thank you very much, Dr. Aini, for your very much inspirational talk. And then we can imagine you will be very much busy as a bee, and then even with the logistic problem and then a lot of challenges and the limited manpower, but I do hope that you can do, okay? And then thank you very much for the both speakers for your very informative and interesting talk. And all right, and ladies and gentlemen, both speakers have delivered their talks on the latest trend and about the matter. Now I would like to bring it to the question and answer section. I got quite a number of questions and sent to my WhatsApp, and then they are lining up in a long queue. Mm-hmm. So I'm going to read them one by one to you all, along with the person who raised this question, and also mentioning to which speaker they have been directed to. So first question is to Dr. Myo.
Yes.
Dr. Myo?
Yes.
Any advice on improving the visualization of gastric mucosal, especially in the case of emergency OGDS, as the visibility may be obscured by blood? This is the question to Dr. Myo.
Yes, during OGDS, with the presence of blood and also sometimes food and drink, the visibility of stomach, we have a problem. So to overcome this, we can wash the stomach through the OGDS and wash with the normal saline and suck out through the OGDS, wash, suck out, and soon the mucosa of the stomach and duodenum become clean, and then we will find, except in case of Forest 2B ulcer, there are blood clot cover the ulcer base. But except the ulcer base covered by blood clot in Forest 2B ulcer, the other area of the stomachs are visible by the washing through the OGDS. Thank you. It is my answer.
Thank you very much, Dr. Myo. And thank you very much. And the second question goes to Dr. Aini. What is why in Sarawak, why colorectal cancer cases come with advanced stage? Whether can we prevent?
Okay, thank you, Dr. Chi. And I think this is one of the topics I mentioned just now, because number one is because of the logistics of the patients. As you know, that we have patients from the rural areas that needs a day or two just to come for screening or investigations. And then for them to know whether they have some problem, it will take a while before they get being referred. And some of them, if they get referred, it will be a delay in terms of the investigations. There will be delay in terms of the biopsy, in terms of every single steps before they get diagnosed. So I would say that one of the risk factor is because of the logistics, number one. Number two is because of the awareness. it's something that for them, if having abdominal pain, having a out-of-bowel habit could be just a normal health problems. So they won't really seek for any advice until they have a late stage whereby they can't even pass motion, they can't even pass stool or even flatus, and this is where they come as an emergency. And maybe the last but not least is the screening program. Again, is because we don't do a population screening, and we only screen people who does have symptoms. So I think this is all. I mean, I might be wrong. It could be other factors as well, but certainly this is what we see on the day-to-day basis at the moment.
Yeah, thank you very much, Dr. Aini. And another question to Ms. Aini. In screening, what are the differences between IFOBT and GFOBT?
So there's two things. I meaning there's immunohistochemistry, chemical IFOBT, whereby there's more sensitive comparison to G, which is goic base. So in terms of the pickup, because the immunohistochemistry is much more biochemical, so a comparison to just the color of the goic base. So we now champion more of the IFOBT. I think most of the centers now use that. G is not longer used as much. I think I don't even have any. I haven't seen any sample that's been sent because of the G base. Previously, yes, but now we know that IFBT is much more sensitive and not as specific, but more sensitive.
More sensitive. Okay. A question to Dr. Myo.
Yes, please.
In Sarawak General Hospital, eradication therapy also needed upon discharge in patient with duodenal ulcer with CLO negative. Whether need any justification?
In fact, eradication of H. pylori infection is indicated those people who has CLO test positive. So if CLO test negative, the thing of the eradication, the justification is that the population prevalence is high. If population prevalence is high, they are afraid of false negative in the CLO test, then may need to give H. pylori eradications for some patients, if I'm not mistaken.
Okay, thank you, Dr. Myo. Very excellent answer. And this question to Dr. Aini. What is the current recommended screening program for at-risks and general population?
Okay, when you if we base ourselves on the current CPG, so people at risk are divided into either low risk, medium risk, or high risk. So most of the patient at risk, besides having the IFBT, the colonoscopy is still the best modalities for them for the screening method. But if you talk about normal population, so what they advise is anybody above the age of 50 up until 75, especially men, advised to have their yearly colonoscopy or we call executive screening as part of their health follow-up. So this is general population at age 50 and above. But unless you have a very risky or even family.
Dr. Myo?
Yes, please.
If bleeding cannot be controlled by the OGDS, what is your next step of management plan?
So it depends on the site of bleeding. Most patients whose bleeding cannot control by OGDS is usually bleeding in the posterior wall of the first part of duodenum, bleeding involving the the artery, a well-known artery, gastroduodenal artery, behind the first part of duodenum. So involving that artery, although we use injection of adrenaline and argon plasma coagulation and even the arterial clip, vascular clip application through the OGTS, sometimes cannot control bleeding. So the surgeon can see continuous bleeding from the ulcer even after the stop bleeding procedure through OGTS has been done. In this situation, we need to inform the main OD and send the patient urgently to OD and open abdomen, open anterior wall of duodenum, and apply an underrun suture to stop bleeding, to tie the artery that causes bleeding behind the duodenum through the posterior wall of duodenum. That is a procedure, the ligation of the gastroduodenal artery through the opening of abdomen, the major surgical procedure and emergency. In that way, we can control the uncontrollable bleeding from peptic ulcer in the scope room. Thank you very much. That would be my answer.
Okay, thank you, Dr. Mio. This is question to Ms. Aini. I think this is from the patient. 58-year-old female who diagnosed with sigmoid cancer stage 3, post-op and chemo 3 years ago, recently done CECT TAP, found out multiple lung nodules, sub-centimeter with some calcification. Lab test CEA fluctuated around 5 to 7. What is your advice for this patient? Who should the patient refer to for further management? Thank you.
Okay, so if she had it done about 3 years ago, I think she might, normally they're still under the follow-up of the primary surgeons and also the oncologists that normally follow them up for that. Number one. Number two is, if this happens, she will need all these investigations again, the colonoscopy to see any intraluminal recurrence, local regional recurrence. The normal, she had the CT scan done, and the last but not least, I think that would be the best will do a PET scan to determine whether the lung nodules are definitely metastatic or recurrence, or whether this is a physiological. But I would really suggest for them to really get a checkup again, because this will involve a few investigations to determine. And yeah, that would be that.
Oh, thank you very much, Dr. Aini. There are a lot of questions. And this is a question to ask Dr. Mule.
Yes, please.
I found that most doctors will simply give gastritis as a diagnosis for epigastric pain. Is there any advice can be given so that a better and more accurate provisional diagnosis could be made? What is your suggestion?
Okay, clinically, the peptic ulcer disease may present with epigastric pain. In the most doctor in the general practice and clinic clinically give the diagnosis of gastritis because the symptomatically it is not easy to differentiate between duodenal ulcer, gastric ulcer, and gastritis. And many patients who come to clinic and have chest pain and no other supporting signs, symptoms for the diagnosis of duodenal ulcer or gastric ulcer. So simply, many doctors give gastritis as a diagnosis and give an antacid like that to relieve the pain and also to change the lifestyle. That's all. My advice is the diagnosis of duodenal ulcer and gastric ulcer should be confirmed by upper GI scope. But upper GI scope for every patient is not possible. So that the clinical diagnosis still be the gastritis and give the antacid and change the lifestyle. But after 1, 2 weeks, 2 weeks, 3 weeks after that clinic appointment, call the patient back as a follow-up and check again the patient whether response to anesthetic or not respond to anesthetic, simple anesthetic, or just stop drinking and stop smoking, the cure the pain or not. In that clinical reassessment, we can diagnose more precisely on the gastric ulcer or duodenal ulcer than the gastritis. Thank you very much. That will be my answer.
Thank you so much. This is some of the suggestions, and then I will read out the suggestion. Good morning, doctors. For cancer, early detection and diagnosis are the most important factors for a better prognosis. To raise the awareness of cancer among the population will be a big challenge. I wonder, is it possible to have some short videos about the cancer signs to be published to the public at the hospital settings? So I think, Dr. Annie, can you take this question?
Yeah, thank you so much for the question. Yes, this is part of what we call the colorectal cancer awareness at the moment. It's what we try to do is mostly in terms of the talks, pamphlets. We're not so much into the video because, as you know, some of you have been to hospitals. We don't even have a TVs in HGH at the moment, except for the main registrations. So maybe it's not possible for it. But if you want to do it as a general population, or you want to distribute it in terms of the social media, yes, certainly that's very, very feasible to do that on top of other modalities of increasing awareness.
Thank you very much. Next question to Dr. Aini as well. Dear Dr. Aini, I wish to know, how does a doctor decide the management of a patient coming with a colorectal cancer? In stage 1 to stage 2 cancer, do we need to prioritize about the patient's condition for operation, or we go straight with operation as early as possible? This is a question to Dr. Aini. Yeah.
So when we talk about colorectal cancers, I know I lump some into one word, which is colorectal, but we treat them according to their anatomy location. So we treat colon as a different entity and rectum as a different entity. So based on all our findings that we had when we do their investigations in terms of their biopsy, in terms of their CT scans, in terms of their colonoscopy finding. So the treatments varies according to their stage, according to their anatomical locations, varies according to the patient's underlying disease as well. Because we know some patients who could have just an early stage 3, but in terms of the health, in terms of the ECOG status, their own health status, they are not feasible to have any big surgeries done. So this decision will be individually based. Not all stage 3 will have the same treatment, all right? Not all stage 2 will have the same treatment, but the main treatment that is being normally offered to them are based on what is the best, or what is the not the best, could be the better outcomes for the patients at that time being. Because one of the another big issues that people always ask me, especially they come with stage 4, and most people think stage 4 is the end of life. That's it. They don't have any hope. They say they will just, they bear with the pain, bear with the symptoms, and will not even undergo any chemo or radiotherapy for the disease. But so now we know it's different. Stage 4 is still treatable if we have the certain modalities to treat it. So to summarize it, it's just to say what's the best treatment in general, or what's the best decision is not fair, because all of them will come in different condition and stage. So the best thing is to seek advice from your surgeons or your oncologist of what is the preferred, best, standardized, or what also the patient wants. Because we always talk about ourselves, But I think at this point, whereby we have lots of very educated patients and family members, they also needs to take up their decisions of what they want for their own body.
Okay. Thank you very much, Dr. Aini. Excellent answer. And there are a lot of questions. This question goes to Dr. Mio.
Yes, please.
How does spicy food causes ulcers? Does more number of chili taken cause more severe ulcers?
So in the study, the taking chili spicy is not the primary cause of ulceration, but it causes more pain, those patients with ulcer or gastritis. And also, the spicy food may stimulate production of more acid from the stomach. But theoretically, they say spicy food is not the cause of ulcer. It is only a risk factor for the one of the risk factors which multiple causes make ulceration. But regarding the pain arising from the ulcer, if a patient is taking more spicy food, then pain will not pain will be more severe. So that many studies said spicy food is related to the pain rather than the etiology of ulcer. So we call it risk factor, right? Thank you.
Thank you, Dr. Mio. I think same questions to Dr. Aini. Any suggestion on food diet to prevent colon cancer?
I have the answer for that. I think I will just resign from Unimas and then sell the idea. So at the moment, sorry, I think that's the goal or the platinum knowledge that I think nobody has an answer to it, right? So, but if somebody has it, I think we just embark on it and then get rich because of that idea.
So probably I will join you after you retire from Unimas. Okay, then this is a question to Dr. Mio.
Yes, please.
And the name of the participant is Mr. Wong. If a patient is on aspirin and OGDS showed gastritis, is it enough to have oral PPI for 1 month? Or subsequently, did he need any long-term PPI?
In that issue, there are consensus on the Asian Endoscopic Society and Western Endoscopic Society, the difference. Normally, the consensus is not to stop aspirin in case of upper GI bleed, as long as upper GI bleed can be controlled. But taking of antacid, what I know is that taking of antacids can make as ordinary people taking antacid for those who have taking aspirin. So no need to prolong the taking of the taking of the proton pump inhibitor for those who are taking aspirin. That will be my answer. But this topic has many debate and consensus, so that I'm not sure the proton pump inhibitor should continue longer time or just give to as usual to ordinary people. But maybe the not giving longer time, just giving the duration as give to the ordinary people without aspirin who has gastritis will be accepted. That would be my answer.
Thank you so much. Yeah, this is question to Dr. Aini. In Sarawak state, between colon and rectal cancer, which is the highest incidence? Which is a higher incidence? between colon and rectal cancer?
It's actually rectosigmoid. It's actually in border between those two. So it's about 30-40% of them will come either they have a big proportion, a small proportion of the rectum part and also the sigmoid part. So those are what we see more at the moment. All right. But of course, if you talk about my practice, I see more of the rectum. But in terms of general in Sarawak, we'll see more of the rectosigmoid.
Okay, thank you, Dr. Aini. Many questions to Dr. Aini. There's alarming questions. Dear Dr. Aini, for tumor marker investigation regarding CEA, is it a specific and sensitive test for colorectal cancer? If the value is high, does patient require to proceed with colonoscopy, or may I know what you will suggest? Thank you.
Okay. So CA unfortunately is not specific and sensitive. It's not I think the numbers are between like 60 or 70%. I mean, but still quite high, but it just doesn't mean that if you have a normal CA, you don't have a colorectal cancers, or meaning that if you have a high CA, you have colorectal cancers. So, but in the event that you do have a high CEA, for us as a medical practitioners, we do have to do further investigations. It can be either imaging, it can be colonoscopy, or it can be sigmoidoscopy even, because CA still, comparison to other GI malignancies, are much more focused towards the colon or colorectal related organs rather than other organs. I mean, there are other malignancies who have a high CA too, but still the most the one that associated with is mostly colorectal. So normally if it's high, without any doubt, I think even I would really suggest everybody to have investigations. I mean, if they do not want to have any colonoscopy because they think it's very invasive, okay, there's also options of CT colonography, or even normal CT scan to see any intraluminal problem. The choice is with the patients if they do not want anything more invasive.
Okay, thank you so much. This question to Dr. Mew.
Yes, please.
In upper GI problem, apart from the bleeding, what you discussed, and any risk of cancer, then whether any way to know early.
Okay, thank you.
Diagnosis.
Gastric cancer is common cancer and fourth common cancer of the world cancer, and it is a serious condition because many gastric cancer are present in advanced stage. So first part of the question is regarding upper GI diseases. How is the problem of gastric cancer? Nowadays, we know that Helicobacter pylori cause peptic ulcer diseases as well. Helicobacter pylori can cause in some patients with unlucky patients, we cause the gastric cancer, arising gastric cancer adenocarcinoma. And there are some concept that chronic peptic ulcer in the stomach can change to gastric cancer is another concept. And this concept is under debate, and something original cancer is become advanced cancer. Okay. So the main cause of gastric cancer is Helicobacter pylori infection. And for detection in early stage is almost not possible because the symptoms of the early gastric cancer, that is involvement of mucosa and some mucosa of the stomach, early gastric cancer is only dyspepsia after the age of 40 years. That is common symptom of early gastric cancer, and most people think dyspepsia, new dyspepsia, is caused by something wrong eaten last night, or blame on the diet rather than blame on the stomach problem. So that patient will not complain to the medical advice, medical doctor with the new dyspepsia after the age of 40 years. So that to detect early gastric cancer, we need screening OGTS. Screening OGTS is only successful in Japan, where more than 100 cases in 100,000 population. That is highest on the world. Comparing to the UK's Birmingham area is around 50 plus cases per 100,000 population. So in Japan, they implemented upper gyroscope screening, upper gyroscope, those who have high risk for gastric cancer, and they get the diagnosis. So the diagnosis is made with the screening, not by the complaint of the patient. So it is difficult to implement in our area, like gastric cancer incidence is not high as the Japan, and so that it is not easy to diagnose in our area. That would be my answer. Sorry.
Thank you so much. This is a question to Dr. Aini. How often to repeat colonoscopy for general population beyond 50 years of age?
Okay, so once you have your first scope at the age of 50, and if it's normal, there's no polyp or there's nothing, so the advice is between 3 to 5 years or symptomatic. So this is when you have it at age 50, then they say the doctor says totally normal. Yes, you can have it. Then we don't give it like a right number, 5 years or 10 years, but we say within 3 to 5 years. Because as if there's a polyp, all right, so we have to address the polyp accordingly. What type of polyp is it? Or whether it's even a benign polyp, you have to repeat the scope again in a year's time. Because polyp is the first sign of, not first sign, it's one of the first indication that any growth can be worsened. So based on the National Polyp Study, we know that polyp, if you don't do anything with it, over 10 years time, it can turn into a highly malignant polyp or cancer. So if you remove it early, you dim patient back to 0. If there's polyp, if there's no polyp, it's totally normal. 3 to 5 years is advisable, right? We don't give a definite numbers, but 3 to 5 years is safe enough. Unless if this year there is normal, next year they have some symptoms, even though they said last year was normal, but we advise if people with symptoms, they have another repeat colonoscopy.
Okay, thank you very much. Our participants are very enthusiastic, still enthusiastic to ask a few questions. This question to Dr. Mio from Lila. Can OGTS done under short GA?
Yes, OGTS can be done during other operation procedure if the procedure require OGTS during GA in main OT. For example, if you are doing operations on the duodenum, for example, but you need the vision inside the lumen. So at the same time, during operation, you can insert OGTS through the mouth to visualize the inner surface of the duodenum, and then you synchronize with the visibility of outer surface of duodenum, inner surface through the OGTS. So it will have the operative procedure more smooth and effective. Thank you.
Thank you, Dr. Mio. And this is a question to Ms. Aini. Dear Dr. Aini, can you briefly explain about IBS, irritable bowel syndrome, and what would be the recommended treatment?
Okay, so what happens normally, people get confused between inflammatory bowel disease, IBD, and irritable bowel syndrome. Okay, irritable bowel syndrome is, for us as a curator, is something that we diagnose after we have confirmed there's no other diagnosis in terms of pathological, in terms of structural, or in terms of any diseases related to the bowel. Is what we normally say is a diagnosis by exclusion. Because we do not want to miss anything that's much more sinister. So patient with IBS, we have what we call specific Rome criteria for it. They will come with symptoms, or there could be alternating constipations and also diarrhea. They have the pain that normally bothers them the most, and then this also affects them psychologically. So worldwide, the treatment of IBS is still not standardized. There are many options of treatments in terms of medical treatments, in terms of psychological treatments, or even in terms of the bowel cleaning, bowel cleansers, or even acupuncture. There's so many other options of treatment for the irritable bowel syndrome. It's just that what for me as a curator surgeon, I do not want to miss any definite diagnosis before I deem the patient to have a irritable bowel syndrome. Because once you deem the patient IBS, it's going to be a lifelong thing. And one of the most, I think, detrimental effect is for somebody to know that they have a IBS and they have to live with it, despite despite their symptoms improve. But it's just that because they have, it's like hypertension. Once you have it, you have it. So it's, before we embark on that, we rather them to be fully investigated.
I think this another question is much related to IBS. This is from another audience. If we have a IBS, can it lead to colorectal cancer?
Okay. Of course, there's no, so far, I can't really recall from any evidence base or any randomized trial data that can specifically relate to that. But if you notice that IBS, sometimes they will have this alternating constipations and diarrhea. The constipation part, sometimes, if you might misdiagnose, over time, they can lead to polyp, constipation for the disease, pathological disease. And we're not sure, over time, whether that constipation can lead for the bowel mucosa to have growth. So this is what I think could be the relations, but I might be wrong. I can't, so far, I never have any, touch wood, I never have any patients who actually had been diagnosed with IBS. One more thing is IBS is something that we don't, in Malaysia, we don't diagnose so much. It's much more Western diagnosis, or maybe much more what we call a upper level or more higher economical people. Kind of diagnosis rather than general population. It's yes, it does exist, but because the research are not as much, it's very difficult for me to really put my ideas into it or give my statement regarding that.
Yep, I agree with you. And then same question to Dr. Aini. Just being curious that will Crohn's disease leads to colon cancer, same like IBS.
Yeah, no. So I think this is one thing that I need to rectify. Okay, IBS and Crohn's, which is IBD, is not the same. It's two different disease. It's two different presentations, and they're two different pathology. So it's IBD is a pathological, it's a well-known disease, and it's divided into what we call the Crohn's disease or the ulcerative colitis. All right. Yes. Ulcerative colitis, yes, there's a 20-30% chance that it will definitely develop into malignancy, colorectal malignancy, whereby Crohn's, despite not as high as you see to develop malignancy, because of the chronic inflammation that you have, because of the disease process that can lead to the changes in the dysplastic changes in the tissue mucosa. But not all, not all will have it, as we know. but there are the predisposition or there's a risk factor that if you don't treat the inflammation, especially the Crohn's, over time, any inflammations can lead to further cell growth and hence the malignancy.
Okay, thank you, Dr. Aini. This is question to Dr. Mio.
Yes, please.
OGDS can done under short sedation. Sedated.
Yes.
Okay.
OGDS can be done under short sedation, correct?
Okay. And another question to Dr. Mio.
Yes, please.
If H. pylori showed high value positive in blood test, can we start irradiation therapy or preferably the patient went for CLO test or OGDS? What is your advice? Thank you.
Yes, it is better to send the patient to OGDS and find out there is problem in the stomach or duodenum, and also take the flow test and to give the eradication, because the blood test is only testing the antigen of an antibody of that H. pylori infection, not directly to the H. pylori infection. So that in that patient, H. pylori is causing disease, or is that patient is just a carrier, don't know, and so better send for OGDS first and then decide whether to eradicate or not. Thank you very much.
Thank you, Dr. Mio. This is question to Ms. Aini. In Malaysia, any national screening program for colorectal cancer, like breast cancer screening? If not, why?
At the moment, no. Right? At the moment, we don't have the big screening as what being subsidized for. To ask about why, I think it's not for me. It's not fair for me to answer because I'm not involved in the program of this guidelines, or even in the national management of colorectal cancers. But I can understand why it's not being done, because the uptake will be very, very difficult, number one. Even, for example, that if you want to do just a FOBT test, meaning we send the kit for everybody in Malaysia, as what I think some other countries did. So you send it to the mail, right? You send it for the patients to give their blood sample back, and then for us to detect who are patients who are going to have positive. Number one, our mailing system is not as great as what the UK system is, the Royal Mail is. Number two, whether the mail will come to us, and number three, whether the patients will return back to you the sample or whatnot. So even I think because the understanding about it is not there yet, right? The awareness and understanding is not there yet. So even though you want to embark on it, I don't think the acceptance rate will be as good yet as what the breast cancer is. So I'm sure there's still lots of things to be done. I'm sure there are people in the national board are thinking about it, about planning to do lots of screening. But if you work in this more specific small areas, I think you can do your own local screening program. I think that's much more feasible than doing a nationwide. I think we try to do so much for the country, but sometimes I think we need to do small things for your own people first.
Okay, Dr. Aini, thank you very much for your excellent answer. So far, I think there is all questions from the audience.
Mm-hmm.
So there's no more questions. And I think congratulations, and really appreciate all of your answers to this talk. Thanks to Dr. Mio and Dr. Aini.
Okay.
And then we have now to the end of our talk. Sorry, last question. Okay. That practice based on the stage and the patient underlying comorbids, as Dr. mentioned earlier. May I know, in overseas, did they treat colorectal cancer with laser or laser photodynamic therapy if patient not keen for surgical treatment? Thank you.
Okay, I'm not sure which specific overseas that you mentioned. Based on my own experience, whereby I work in certain centers as mentioned before, Korea, Bangkok, and UK. So far, we don't have it yet. Okay, but you have to understand what does it mean by laser, because in layman's term, laser is just a laser photodiode, but some lasers are not just laser. There's specific kind of lasers that could be treated. So to my practice, up until I finish my training, we don't have it as a part of the options for the patients yet. But I might be wrong. I might be not up to date. Maybe now they have it in other places. Maybe it's more for temporary measures and also to improve the symptoms. Right. But the main treatment for most colorectal malignancies are mostly surgical resections.
Okay, thank you very much, Dr. Aini. Mm-hmm. I think this is all of our section today. And then thank you, Dr. Myo and Dr. Aini.
Thank you very much.
Thank you. And then we have now come to the end of our talk. And then I would like to call this whole event a great success. And I would like to express my words of thanks to the both speakers for sharing their expertise over the respective topics, and also to the audience for their keen interest and enthusiasm, as well as their active participations. I do hope the presentation has really been beneficial to every single one of the audience. Thank you very much for your attention. Take good care and have a nice day, and a bye-bye. Thank you.
Bye-bye.
Bye.